So once again, good morning, good afternoon, and good evening to you all. Welcome again for joining us for this webinar series. And today we are talking about the Speed Up Scale Up TB testing campaign. And particularly, we are talking about which tests go where. In this session, we will be diving into optimal placement of TB diagnostic tools as part of the National Diagnostics Network to reach more people. And some of you are wondering that I have welcomed you and said hello to you, but I have not introduced myself. My name is Alice Kayongo. I do work with the Center for Global Health Policy and Politics at Georgetown University School of Health and Law. And today, we are building on one of the webinars that we conducted on September 11th that was basically talking about maximizing impact of newer emerging diagnostics. But before we get into the program today, it will be unfair for me to get into the program without talking about the DEC, or the Diagnostics Equity Consortium. The Diagnostics Equity Consortium is an initiative that brings together communities, civil society, and experts to advocate for better diagnostics and to ensure that there is access to diagnostics, particularly in low and middle income countries where healthcare systems need a lot of support. The DEC seeks to reshape diagnostics policies to improve healthcare practices and to monitor progress through advocacy, through research, and through community-driven initiatives. Like we have always said, think about the DEC and civil society as superheroes of the diagnostics world. We are superheroes, but we don't have the capes on. That is fine. We want to change the world, especially when it comes to diagnostics. And just so you know, the DEC is proudly hosted by the Pan-Africa Treatment Access Movement in Zimbabwe, as well as the Center for Global Health Policy and Politics at Georgetown University's Schools of Law and Health. And our mission is basically we want to ensure that we are fostering literacy, we are fostering demand, we are fostering understanding of anything around diagnostics. So in the DEC, we speak anything around diagnostics equity, especially in low and middle income countries. Today, we have a couple of experts who are going to speak to us. We have said that we bring you closer to the experts, or we bring the experts closer to you so that you are able to understand and appreciate these issues, but most importantly, be able to advocate for equity in diagnostics around the world, but most importantly, in low and middle income countries. So we'll have a couple of presentations, a few of them. We'll have a video recording, and we'll have my favorite, the question and answer session, where we will see and listen and hear what people have to ask about the presentations that will be made. But before we get into that, I want to hand over to my colleague, Sharon Ann Lynch, who is a co-director at the Center for Global Health Policy and Politics. And Sharon Ann will talk to us about near point-of-care diagnostics. Over to you, Sharon Ann.
Thank you so much, Alice, and thank you all for joining. Alice said that we want to change the world, and it's true. The Diagnostics Equity Consortium, what we want is equitable access to life-saving tools, including diagnostics. What that means in terms of what our responsibility as civil society is, we want more literacy, we want more knowledge, and people to be equipped across communities and civil society about the tests that should be at their local clinics. We want more accountability when it comes to duty bearers that both commit to and provide the package of essential diagnostics across facilities. And we want more advocacy. And of course, we are activists that are informed by evidence and arguments. And so our advocacy has to be informed by our literacy. So we both teach each other and we know enough experts in order to reach out and have them share their knowledge with us. So I'm grateful to the subject matter experts that are on this webinar. In terms of today's topic,
2:07 p.m.
we know that TB has been faced with this challenge for quite a long time, which is that deadly diagnostic gap, the fact that we're not finding, we're not diagnosing, and we're not treating people with otherwise curable TB and its drug-resistant forms. So now the pipeline is rather promising. There are diagnostics in development, and at least one that is now out of the pipeline and to be evaluated by WHO that could be suitable for the primary healthcare level and even below. So the so-called near point of care tests hold a promise of being able to bring testing down to where people seek care at the primary healthcare level, and they're rapid, accurate, and easier to link people to the care that they need. So I want to say thank you again, and I hope that we can align behind actions in order to extract ambitious commitments by government. And thankfully, there are some global health actors that have already committed to provide support, to provide the funding and provide technical assistance for the rollout and scale up of these tests. And you're going to be hearing more about that on this webinar. So back to Alice, and thank you all again.
Thank you so much, Sharon. I totally agree with you that there's so much that needs to be done, and we need to align behind lots of actions to ensure that our governments are providing ambitious targets and ambitious plans to ensure that diagnostics are getting to the people. And that we have diseases, TB, being detected as soon as early as possible. For those who have just joined us, welcome to the Speed Up Scale Up webinar series. This is our second webinar series, specifically talking about we are building on the first webinar that was talking about maximizing new and emerging diagnostics. But today we are specifically diving into which tests go where. And second on our agenda today is Miss Melanie Kitongo, who is who works with the Global Fund, and Melanie will be talking to us about the potential role of near point of care tests in achieving the UN high-level meeting targets and the Global Fund's strategic initiative. Over to you, Melanie.
Thank you, Alice. Can you confirm that you can hear me clearly?
Yes.
Good afternoon, good morning, good evening, everyone. I'm happy to be here. My name is Dr. Melanie Kitongo. I work on the TB team here at the Global Fund, and I'm really happy to be here to present these slides. Next slide, please. I'll start with a quick overview of the Global Fund investments in TB diagnostics. And in the current grant cycle, which is grant cycle 7, that ends at the end of 2026, the Global Fund is investing close to $600 million US dollars in TB screening and diagnostic tests over this 3-year period. And this amounts to about 25% of our investments for TB. Our allocation for this grant cycle is about $2.4 billion. And so a significant proportion of that is actually going towards increasing access to TB diagnostics. And majority of that money, over 50% of our investments, goes towards health equipment, tests, and PSM costs that really are helping drive the access to molecular diagnostics. We're also investing in other service delivery costs that are associated with active case finding activities, sample referrals, trainings, and HR support. And so the graph over there just shows what we're investing specifically for TB screening is about $400 million, and then for drug-resistant TB and susceptibility testing is about $174 million over this cycle. Next slide. And so it's really critical to understand what your diagnostic network looks like to support how you make decisions around new diagnostics. And the Global Fund has previously supported DNOs, which help countries to plan for future development of their lab system in line with what their national lab strategic plans are. And knowing and understanding what your diagnostic network helps to break down any silos between diseases, so you can look for more integrated solutions that are more patient-centric. And then they also increase access to testing and leveraging existing resources, which helps increase cost efficiency and releasing funds that can help support further system improvements. And so the Global Fund has really been a key partner in the countries that we invest when it comes to understanding what your diagnostic network looks like and how you can have the support structures to help it improve. Next slide, please. And so I'll go into what the Next Gen Market Shaping SI is for the Global Fund. In Cycle 7, we have a specific strategic initiative that is aimed at improving equitable access to health products across the 3 diseases that we invest in, so HIV, TB, and malaria. For TB specifically, the interventions for this cycle have been aimed at supporting improved access to quality diagnostics. We are fully cognizant of the fact that the TB diagnosis is really the weakest part in the TB care cascade, and we're trying to work with partners and with manufacturers to make sure that we improve access to molecular diagnostics, but also for the products that are in the pipeline to make sure that they are introduced as quickly as they become available. And so this SI in this cycle has 3 main components. And the first one is around estimating what the market size looks like for these new near point of care diagnostics. And then we're doing a couple of regional engagements to support demand for the introduction of these new diagnostic tests. And we also have a pot of money that will be used to provide technical assistance to countries once these tests are approved by WHO. So we've been scanning the pipeline for a number of products which are listed here, but I think the one that's most exciting to us at this time is the near point of care diagnostics, which offers the potential to decentralize testing to the PHC and in the community, but also comes with a new sampling type, which is the tongue swabs that can really help children and people living with HIV who have previously had a really hard time producing sputum. And so in July of this year, the Global Fund ERPD approved the first-in-class product, which is the PlusLife platform. And so that makes that platform eligible for Global Fund procurement. And so what we're working with now is a group of early adopter countries to see how we can accelerate the rollout in 2026 to learn as much as we can about where the tests can be placed, what the algorithms will look like, what training needs will be needed, HR needs, so that once we get into the grant cycle 8, we are fully equipped with as many tools and as many programmatic insights that can allow for a rapid rollout. But also calling out that in November of this year, there'll be a WHO GDG that will look into this new class of diagnostics as well as the new sampling type of tongue swabs. And hopefully that can also help accelerate the rollout of these platforms. Next slide, please. And so diving deeper into the near point of care TB diagnostics, I think from the Global Fund perspective, we're really excited about it because it helps address a number of challenges that we have in the diagnostic care cascade. And so the first one is around the access gap. We know that about 8.2 million people were diagnosed with TB in 2023, but that leaves about 2.6 million people who still need access to a TB diagnostic test. And then we also know that the percentage of people who are receiving a WRD, a WHO recommended molecular diagnostics, are less than 50%. And so we have 52% of people who are either clinically diagnosed or are using sputum smear microscopy, which is a century-old diagnostic test. And so the near point of care TB diagnostics really offer the potential to help us reach the UNHLM target of 100% of people diagnosed with a rapid molecular test by 2027 by helping us close the access gap and the quality TB diagnostic gap. Next slide, please. And so we see the NPOCs as not just a tool, but a new approach. In terms of access, I've mentioned that we're decentralizing it down to the PHC level, which will increase access to communities and then allow patients to get same-day treatment initiation. Tongue swabs, which are the new sampling types that will be coupled with these platforms, are beneficial for children and people living with HIV who struggle to produce sputum. The quality component of it is really key because we know majority of the TB patients are diagnosed with smear microscopy, and these tests are significantly better in terms of sensitivity, and so you're likely to receive to diagnose even more people by just simply replacing your diagnostic microscopy with a near point of care diagnostic. And then the big component really for us, and especially from the Global Fund perspective, is the cost. In the current cycle, we have had a lot of challenges with the current cost of WRD cartridge costs, which are honestly unsustainable. And so these new near point of care diagnostics offer us a potential to rapidly and quickly reduce the cost of diagnosing a TB patient with a molecular diagnosis. And if these tests are placed right next to a GeneXpert or a TrueNat, because they won't be a replacement, they're just complementary, they will really drastically reduce the cost of diagnosing a TB patient. And then you can maintain the GeneXpert tests and TrueNat for sensitivity testing. So we really see this as a really new approach in terms of diagnosing TB patients in a way that's sustainable for a lot of the countries that we support. Next slide. And so it's important to understand how these new near point of care tests fit into an existing diagnostic network. What do your sample referral systems look like? What are your HR requirements? What's the infrastructure that you have? What testing devices do you currently have, and where would the near point of care test best fit? And so some of the goals would be, you have to get the right amount of testing in the right place at the right time for the right people, and specifically at an affordable and a sustainable cost. And then ensuring that the accurate test results are delivered to the patient on a scale that's consistent with the national goals. And we see the near point of care test being able to deliver on a lot of these goals for the diagnostic network. Next slide. And so we've been having a lot of regional engagements. We had one in Abidjan last year, and then in Asia, in Vietnam, and are planning to continue this dialogue at the ASLM meeting in October. But what has come out of those meetings has been what are the possible ways that countries are thinking of using near point of care diagnostics. And so one of the ways is really cost containment. For countries that really have a high coverage of WRDs, even those that don't actually have been grappling with the cartridge costs, which are currently unsustainable. And so if you place this test right next to a GeneXpert, you are likely to really reduce the number of tests that actually have to be filtered off for drug sensitivity testing. I've talked about the improvement in quality when you replace a diagnostic microscopy with this, just to highlight that it's not going to replace follow-up microscopy. So microscopy will still be needed, but you're offering a much better quality test. And the assumption around here is that these sites are already linked to existing infrastructure, HR, sample referral systems, treatment initiation. And so the cost of change will be minimal. But the area where we see the largest impact is decentralization to PHC levels, to the community. But we know that this will require a lot of change management in terms of infrastructural costs, decentralization of TB treatment, linking sites that have previously not been a part of the sample referral network. And so we see this as a stepwise approach to getting towards a PHC level diagnostics, but the engagements that we've had in the different regions have really been key in highlighting what are the different ways that countries would think about using near point of care diagnostics. Next slide. And so then as I wrap up, and I think this is my last slide, I'd like to say from the Global Fund perspective, while we're trying to drive access and affordability, we're really key on integrating the procurement strategies for multi-disease diagnostics. So in line with our next-gen market shaping SI, we are currently implementing an integrated molecular diagnostics procurement strategy to just create better conditions for cross-disease use of these tests, so you can allow for a combination of HIV, TB, and other diseases, which can improve the commercial leverage and hopefully help stimulate lower prices for TB. But in addition, we're regularly engaging with suppliers and as part of our procurement process, and closely monitor the progress of any new multi-disease diagnostic platforms to bring additional competition into this space, while we're also keen and looking forward to the near point of care diagnostics that will hopefully get a WHO guidance at the end of this year. So I think that should be my last slide. I'd like to thank you for the time, and I'm happy to answer any questions. Thank you.
Thank you so much, Dr. Melanie. Indeed, you raise a couple of key issues. The fact that TB diagnostics is actually the weakest in the TB cascade. That's definitely a huge, should I say, disservice, a huge gap that we need to address. And also given the fact that 2.6 million people are still not able to access a TB diagnostics test is signal enough that we need to pull up our socks and ensure that TB diagnostics are getting closer to the people at primary healthcare level. Melanie will not be able to stay with us for long, but at this point, before she leaves, I want to encourage us to ask questions. Please ensure that you are making use of the Q&A chat so that you can pose your questions. But even before that, maybe one or two people have questions for Melanie before she leaves. If not, please feel free to place your questions in the Q&A chat. So I'll pause here for a few minutes and see if there is any question for Melanie. Melanie, it's highly likely that we will have questions in the Q&A box. So we will be sure to get back to you. Somehow, somewhere, we will get back to you for responses. Please look out for our messages, to be able to respond to the questions that our colleagues will have.
Thank you.
Thank you, too. So having heard from Dr. Melanie, we'll move on to our next speaker. This is actually a recording from Teju. Teju will be talking to us about trade-offs and considerations for point-of-care testing. There is no volume. Ali?
Sorry, is the volume not working?
We can't hear anything.
While we're waiting, there are a couple of questions directed to Melanie, about 5 of them. And then I think there's one for you, Alice, because Sabira is asking about how to join DEC. Do you want to go through that while Ali figures that out?
Oh, that's good. And thank you for raising that. I wasn't able to see my chat box. How do you join DEC? Please send us an email and you will be included on the DEC listserv. You can send your email to ak2141@georgetown.edu, and we'll place that in the chat box as well. So just drop us an email and we will be sure to add you to the DEC listserv. And welcome to the superhero team that will be discussing everything diagnostics, TB diagnostics, and more. I don't know if, fortunately Melanie is still around, and I know that Melanie will be responding to some of these questions. Melanie, would you want to get back on for a few minutes to respond and then maybe you can respond to others in writing.
Yes, I've been trying to answer. I think I've answered one on the integrated. The first question, I think, was from Damien around telling us more about the integrated diagnostic procurement strategy. And I've just shared a slide deck that hopefully summarizes what the. Can you hear me still? Summarizes what the Global Fund intent around integrated molecular diagnostics. I think towards the end of last year, we issued a tender that was allowing for molecular diagnostic manufacturers who offer multiplex diagnostics. And so our preference now as part of the Global Fund strategy is really to invest in molecular diagnostics that are cut across at least the 3 of the diseases, but even beyond, just so that we're trying to think about it in a less siloed way. And so that I think the presentation will probably provide more insight on that. Let's see, TB-DNO is a significant process to streamline and optimize TB testing. Use it in a few sites in India, but the software tools, but if the software tools are open source, it will really help. Exactly. We see the benefit of TB-DNOs, but we know that they can be quite costly and time consuming. But we know that there are also a number of partners. Find has developed a simplified Excel-based tool that can help do the same almost the same output as a DNO. And I think I can hopefully just find the links and share those with you in the chat so it doesn't take too much time. Rosalind is asking what the Global Fund is doing about the technology. So as I had mentioned, for the near point of care diagnostics for the first-in-class product PlusLife, the Global Fund is going to work in a set of early adopter countries in 2026 to see how we can co-finance the rollout of these tests and provide technical assistance that will help address some of the programmatic issues around introducing a new tool. And so we hope that that will help further scale up in GC8. I think I'll stop there. If there's any questions I've missed, I'll just quickly scan the chat and answer them directly. Thanks.
All right. Thank you so much, Melanie, and huge thanks to the Global Fund. And just to remind us all, these webinar series are actually being conducted by the DEC in partnership with the Global Fund. So we are truly grateful to the Global Fund, not only for supporting these webinar series on literacy around TB diagnostics, but also for supporting the scale up and technical assistance on basically funding TB diagnostics in different countries. Thank you so much, Melanie. Please pass on our gratitude to the rest of the Global Fund team.
Thank you.
A reminder for all those who have questions, please feel free to post your questions in the Q&A chat and you will be receiving responses. Please remember that we are not with Dr. Melanie for so long, so if you have any question for which you require her response, kindly take advantage of this time when we are still with her. Ali, are we okay? Are we good to go with the recording?
Yes, I think it should be working now.
Fantastic.
Hi, everyone. Thank you for having me here. As Mangala said, as we're moving forward with these new exciting tools in the pipeline, I'm going to be covering a few of the trade-offs and considerations that we need to keep in mind with using tests that have alternate sample types and also considering where these tests could be placed. Next slide, please. So you already heard about this from the first webinar, but I just wanted to do a little refresher on it. But the WHO standard comprises of 12 benchmarks that are to be computed by countries in the 4 steps of the diagnostic cascade. So you can see the 4 steps over here and the 12 benchmarks laid out under them. But I wanted to draw your attention to 3 specific things over here. So with accessing tests, one of the things that the WHO calls for is WHO recommended rapid diagnostics access in primary healthcare center, the provision of universal drug sensitivity testing, and timely delivery of results. So while we look at these new tools in the pipeline, a few of the things that we need to keep in mind for evaluating them is one, placement. If they have the ability to test for drug sensitivity, time to result, which in turn means treatment initiation and how quickly that could be done. Next slide, please. So again, while Grania did mention that a lot of these tools are near point of care, and this is an exciting new class of tools in the pipeline. Again, this is something that was mentioned in the first webinar, but just as a highlight, as a reminder, this is what point of care, near point of care, and low complexity actually mean in terms of equipment, infrastructure, and HR skill levels. So while we talk about near point of care, they are mostly battery operated in terms of equipment required, don't necessarily need too much infrastructure in terms of the labs that they're placed at. And with HR skill levels require basic technical skills, so basic pipetting and not necessarily critical precision. These are different from true point of care tests, which require no equipment, no infrastructure, and none or minimal skills, which could be ideally a self-test or a self-sampling test. But this is what we need to keep in mind with what's needed for near point of care tests. Next slide, please. So coming to tongue swab-based near point of care TB tests, several companies are developing rapid molecular diagnostics for TB detection, and these are using small and fast testing instruments, and these are designed to be implemented at the point of care in the community and primary care facilities. And one of the biggest contributions of such tests is that they could enable same-day testing, diagnosis, and treatment initiation. But one thing that, again, we need to keep in mind while we talk about diagnostic accuracy is that tongue swab samples are expected to be less sensitive than sputum samples. So while we're having a sensitivity of about 70% with tongue swab samples, sputum samples usually give us about 90% sensitive tests or more. But the benefit of this is that nearly everyone can easily provide a tongue swab sample, and more people will be able to receive a diagnosis. I think we're all very aware of the limitations with sputum, and a lot of people who are sputum scarce are not able to provide sputum easily, and how that's a big barrier to testing. So this tongue swab-based samples kind of overcomes that gap in TB diagnosis. But another thing, as again Grania mentioned, is that these tests are only yes or no TB tests. So they only detect TB, but as per the WHO standard, they don't necessarily provide DST or tell you your resistance to the treatments that you're going to be on. So they will need to be linked, and you need further testing for drug resistance. And ideally, this would be using near point of care molecular DSTs. Next slide, please. So I can just go on while I wait for the next slide. But while we're talking about this, the main trade-off that we're thinking about with these tests is if we're willing to trade accuracy for access. So to address gaps in the cascade of care, we need to make tests more accessible, and accessibility or more accessible tests enable more frequent and widespread testing. And this could also increase the diagnostic yield, which is a metric to measure the performance of the test, similar to diagnostic accuracy. So it's the proportion of people who are identified with a disease using a diagnostic test out of the total number of people who are eligible to be tested. And in order to increase the diagnostic yield, we need tests to be available closer to the point of care, require accessible sample types, and however, both of these can affect test accuracy. So the main question that we're kind of grappling with over here is if a less sensitive test is acceptable, if more people are able to access it. Next slide, please. And this is empirical evidence from a modeling study that kind of looks at the question that was just posed. So it looks at point of care TB tests with minimum sensitivities of 70% and non-sputum samples for non-sputum samples and 78% for sputum samples. The study found that these could achieve comparable or better case detection rates than current standards of care. This modeling study was, or results or evidence from this study was used to inform the WHO target product profile. And the models or the assumptions built into the model is that the current standards of care was evaluated in 3 countries. So that's Kenya, South Africa, and India. And in Kenya, it's expert or smear microscopy. In South Africa, it's the 4-symptom screening and expert confirmatory testing. And in India, it's the expert or TrueNAT smear microscopy and clinical diagnosis. So given these current standards of care, if we have minimum sensitivities of 70% or 78%, we could still achieve the same level of case detection or even better, perhaps. Next slide, please. So this again is from the same modeling study, and it's a graphic demonstration of these trade-offs that we're talking about. So it shows you the potential benefits of having a less sensitive test that more people can provide samples for. So if you see the graph on the right, the smaller blue square shows you 25% of the access rate. Is the number of people who are able to provide samples. So think of this as maybe like a sputum based tests, and a fewer number of people are able to provide samples and access these tests. So in this small group, it's extremely accurate. So it has a higher accuracy, but in a very small groups. Only the smaller blue box are people who are able to provide samples. So just to keep in mind that the high rate of accuracy is in a very small group. But if you look at the graph on the left, you see a bigger blue square. So this probably is a test with a more accessible sample type, such as an oral swab or a urine test, which a lot of people can provide these samples, but it's less sensitive. So you see that it has a lower sensitivity and lower accuracy rate, but still a lot of people are able to, many more people are able to get diagnosed through this test. So when you think about these kinds of tests, and if you ask people what they want, and if you're kind of taking a preference survey, people would say that they want a faster test or a more accurate test. But if you give end users and national TB programs these considerations and these trade-offs, this is the kind of information we need to have to know which one you would choose. Again, I just want to put in the caveat over here that this is a hypothetical modeling-based scenario, but we need to test these out in practice and kind of collect data on diagnostic yield to know if this holds up in real world. Next slide, please. So while we're talking about alternate sample types that have lower accuracy, I also just wanted to highlight 2 different kinds of tests that have more accessible sample types, but have proven benefits despite lower accuracy. So stool samples for children are less sensitive, so it's about 50 to 67% of accuracy, but it's proven to increase yield. So in practice, NTPs in high burden countries are already implementing stool-based testing as the first test for children with presumptive TB. And in Nigeria, they found a 4.8% yield from stool-based testing compared to 3.5% from a sputum-based test. And a study in Ukraine found a high concordance of test results between stool and respiratory samples. So this is about 81% of concordance between these test results. And the urine samples for people living with HIV, Abbott's Determine TB LAM is, again, as we know, a low sensitivity test with sensitivity only ranging from 35 to 42%. But again, this is a group that's usually vulnerable with TB diagnostics and not being able to provide accurate or spontaneous sputum samples. So this urine LAM test, despite its low accuracy, is proven to have mortality benefits and reduce mortality by 15% among people with advanced HIV disease. And what this test kind of does is it highlights the importance of early detection and treatment initiation. So despite lower accuracy, there's there's many benefits that go across the different parts of the care cascade. Next slide, please. So this is just some preliminary results from accuracy of oral swab testing for pulmonary TB. Again, Morten presented some of this in the first webinar, but this is for the first two tests are PlusLife and TrueNat, and this is based on accuracy data that was presented at the Union conference from R2D2 studies. So you can see that the sensitivity for PlusLife is about 88.5%, and for TrueNat about 77.5%. So these still meet the WHO target product profiles, but are definitely lower than sputum-based samples. But these are oral swabs that are being collected. And you, as Grania mentioned, you can see that the price is lower than what the current testing is going for. And there's also the Expert MTB RIF Ultra, which is which has about 74% sensitivity. While Sputum Expert Ultra is the reference standard for these studies, it's also important to know that there's other developers entering the market, which is a good thing, because to overcome the long-standing monopoly that we've had in this field of TB diagnostics. But again, with accuracy in children, I wanted to highlight that children could most benefit from oral swabs because they do struggle with sputum, but unfortunately we see that we still have lower sensitivity of these tests in children. This is from a systematic review that shows you that sensitivity is ranging from 5% to 42%, which is fairly low. But again, I just wanted to put out a reminder that stool sensitivity is about 50 to 67%, but is still recommended by the WHO. So while we don't have too much going on in this space, something is still better than nothing. So if we're dealing with the upper end of this being 42%, then we kind of have to make do with what we have until we have something better for this vulnerable population. Next slide, please. Switching from accessibility of sample types, I wanted to move to the proximity to point of care and where these tests are placed. This is results from two large-scale clinical trials, the EXPEL TB and TB CAP study, which shows you that providing rapid molecular TB testing at the point of care in high-burden countries leads to faster diagnosis, quicker treatment initiation, reduced patient loss to follow-up, and increased overall TB case detection as compared to centralized testing. The EXPEL TB had the intervention strategy of placing molecular tests at community health centers, and this led to a 56% higher rate of treatment for confirmed TB within 14 days compared to routine care. And TB CAP looked at implementing the MolBio TrueNat test in primary care settings, and this resulted in 82.9% of people with TB diagnosed and started on treatment on the same day that they presented to care, and 98% started on treatment within 7 days of presenting to care. So you can see immediately the results having faster diagnosis and quicker treatment initiation. Next slide, please. And one thing I wanted to, again, talking about the DST considerations over here, we are, with the accessible sample types, we're trying to close the gap of people who can't produce sputum and have more accessible sample types. But while we're trying to get rid of sputum, we can't do with it right now, I also wanted to highlight that we're not yet ready to get to a place where we don't rely on sputum at all. We can't do without it right now as well. We're continuing to rely on sputum for DST and testing resistance profiles, as well as treatment monitoring. So while we need universal DST, and this is something that the WHO standard calls for, we can ask the question of, does it all need to be in one test? So over here, I'm talking about a reflex testing algorithm where for the first step, you're screening at the point of care using accessible sample types. And step 2, you're linking that to further diagnostic testing at the near point of care, which is including DST. However, a few considerations with this algorithm is that it's mostly justifiable in low drug-resistant TB prevalence settings, but ideally it would reduce burden on on the healthcare system, because you're not doing a DST for every person coming in. You're also reducing loss to follow-up and same-day treatment initiation. But this algorithm would work with a good transport system and good monitoring and evaluation. And again, I wanted to highlight over here the importance of community and end-user literacy and the important work of outreach of community-based organizations for having an algorithm like this work well in high-burden settings. Next slide, please. So while we need to perform a lot more tests to close the gap, we do need to keep in mind resource constraints, especially in the current situation. We need better funded programs and we need well-priced tests. This is an example of Nigeria, which shows you a funding gap of more than $1.1 billion. And you can see from this that the main gaps are in diagnostics, mainly in the individual cartridges. So irrespective of intent, ambition, previous progress, funding is what is the biggest contributor to the gap, to the diagnostic gap in Nigeria right now. But again, on this note, I do also want to acknowledge the impact of recent shifts in international funding on TB programs, given the current USG administration's withdrawal of foreign aid, and also similar moves to cut official development assistance in countries across Europe. So while this is the case in Nigeria, we know that a lot of countries might be and will be facing similar situations, and we do need to be cognizant of that. Next slide, please. And again, talking about affordability of TB tests, this is a critical funding gap from the Stop TB partnership, and I've highlighted a few boxes over here, and you can see that TB cartridges have the biggest funding gap and are the biggest gap in diagnostics. Again, this was mentioned by Mangla in the first webinar, but this is a technical briefer from MSF Access Campaigns on the Time for 5 campaign, which shows you that when Danaher reduced the price of the expert cartridge from $10 to $8 after a lot of public pressure from the campaign. This $2 price reduction by Cepheid on the standard TB GeneXpert test showed us an actual reductions in prices projected. And the Global Fund said that they were saving $32 million, which could lead to procurement of an additional 3.6 million expert TB tests per year. So while we know that, we know that if we have tests that are more affordable, this is a gap that we could close and have more frequent testing be done with more affordable tests. Next slide, please. So some of the key themes I touched upon in this presentation were trade-offs and considerations, mostly have to do with access. We're talking about sample types, and with sample types, we need easily accessible sample types. And this could be, over here, we're talking about oral swabs, but this could be urine, blood, stool. And these accessible sample types should be prioritized for new diagnostic development. And we know that despite lower accuracy, they do increase yield. And that is something that could massively help in closing the TB diagnostic gap. And with use cases and diagnostic placements, we need point of care or near point of care placements in community and primary care setting where people are first presenting to care. And this can enable same-day testing and treatment. And while we talk about point of care, we need to also ask what about self-sampling and self-testing? And is this something that could be possible for TB? And similarly, what should follow on DST look like in practice? Grania spoke about network optimization. So where should these rapid molecular DSTs be placed to minimize sample transport delays and minimize loss to follow up? And to end on funding, we need well-funded TB and primary healthcare programs. A lot of these tests can detect multiple diseases at the same time. So we could push for disease testing integration so that the burden doesn't fall entirely on national TB programs. And it also makes care seeking for the end user much easier to navigate, not that it's ever easy to navigate. And lastly, we do need cheaper tests, and we need tests that are scalable and tests that can be incorporated in low and middle income countries and high burden settings. Next slide, please. So I just wanted to point out that Treatment Action Group has the 2024 diagnostics pipeline, TB diagnostics pipeline report, and the links out over here, but it goes over all of the different TB tests in the pipeline and kind of touches upon some of these trade-offs and considerations. Thank you. Happy to answer any questions.
Thank you. Thank you so much, Teju and Ali,
Hi, everyone.
Who has helped us play this recording. I know there are some questions. Please remember to place your questions in the Q&A chat box and you will be getting responses. Alternatively, you can come off mute at some point later in the agenda, but for now we will be moving on very quickly to Shaukat Khan, who's the Director of TB Diagnostics at Clinton Health Access Initiative, commonly known as CHAI. So yeah, over to you, Shaukat. And Shaukat is going to be talking to us about TB Diagnostics placement strategies and implementation strategies across several countries. Over to you, Shaukat.
Thank you, Alice. I hope everybody can hear me.
Yes, we can hear
Perfect.
you.
Thank you. Thank you for the opportunity to present some of this work. So, usually when we talk about like optimizing deployment, we usually have a lot of experience on a product, and we've done a lot of implementation studies on the ground, and we could confidently talk about like, how best you should be placing your devices here. As you know, these products are very new. They haven't really been tested on the ground yet. So a lot of the stuff I would be actually kind of talking through is based on the modeling work that we've done and country consultation across multiple countries. And initially, it's a lot of this work was actually funded by Global Fund, and I'll be showing some of the data from that work that we did in collaboration with both FIND and ASLM. So next slide, please. So first, I just want to set the scene here. I know Melanie just kind of told you guys like the high numbers around like, globally about 40, half of the patients who are notified are actually never tested a molecular test. They get tested either through microscopy or they're just diagnosed through clinical diagnosis, and that does actually vary country to country. Not every country has the same setups, but globally, that's the trend. And even if we look in Africa, this is sort of approximately about 10 countries that we looked at. You see that like a lot of high-burden countries are still actually relying on molecular testing. So DRC is a pretty good example where only about 14% of patients who are notified, they were actually tested on a LCNAT, like a gene expert. Rest were actually tested on either microscopy or just clinical diagnosis. And essentially, also you kind of look at the trend, we're still missing about approximately 25% of patients as well. And partially the reasoning behind this is that where the tests are and where the people come are not the same places. And I think that has been essentially the theme for both of the conversations, two presentations we already have. And I'm assuming pretty much every conversation we would have is that where the testing is needed, we don't actually have the test. So we end up actually missing a lot of individuals. Next slide, please. And this is sort of like kind of reiterates that point. So we actually like what 4 or 5 countries, we actually had their master facility list. So we knew exactly where the facilities were in country, geocoded. We also knew whether they had LCNAT available or not, whether they had microscopy and where they were doing treatment. And if you look at it, majority of the countries are able to provide treatment at a PHC level. Some countries all made up to 100% and other anywhere from 34 to 36%. And that has also to do with like, some facilities, countries that also have community health level as well, which don't usually provide treatment, but a primary health clinic pretty much in all countries do provide treatment. And they usually just rely on sample transport to be able to send those samples for diagnosis to another site. So essentially you're limited by there's sample transport available on the day a patient might come, as well as how sick the patient is, whether the healthcare worker takes the sample or not. So because of that reason, sometimes people just get diagnosed based on clinical diagnosis and they don't necessarily receive a molecular test. And when you look at like a placement of LCNAS, like a GeneXpert, like not majority of the countries, maybe like 1%, 2% of facilities actually have an LCNAT available at site. But microscopy, on the other hand, approximately about 30% and some of them are 10 to 30% of the facility would have a microscopy lab available. Whether they are always doing microscopy or not, that's dependent, because when we've noticed that in some countries, when they run out of GeneXpert cartridges, they will rely on microscopy. When they have the GeneXpert cartridges, they will send those samples for GeneXpert testing. But we know that there are microscopy sites, and there's actually an HR available there who can potentially run any near point of care test as well. So by thinking about it this way, like, for us, microscopy center actually becomes a really good use case, because this is where the patients can actually access the test. Next slide, please. So just to kind of talk about, like, we know GeneXpert is very good. I mean, its performance is amazing, as well as it has drug resistance testing. But both GeneXpert's TrueNAT, all the LCNAT that have been approved by WHO, the device costs are high, assays costs are high. There's a lot of infrastructure requirement. You need to have ACs, you need to have computers, some dedicated space, and also you need to have a really good sample referral system, which in a lot of countries we don't have it, because a lot of countries can't afford to have sample transport every single day available at facilities. And then sometimes, they only provide sample transport if a sample is collected before 9 a.m. So it really kind of limits how many patients can get a test done. However, if we move toward NPOC, that's where the real value of NPOC comes in, is that it can work both with sputum samples and it can work with swab sample. And as Teja kind of mentioned, swab, the performance is, yes, lower, about 75 to 85%, depending on which study you look at. But you can also actually just use a sputum sample on these devices, which would actually get you performance close to 90%. These tests are lower cost as well. We expect the prices to be less than $4. The price of the devices is low as well. We're expecting less than $400 for devices as well, and they're easy to conduct. So we think that due to the ease of running the test, we can have task shifting where a technician at a microscopy lab can potentially run these tests, or at a sputum collection point, a healthcare worker can potentially run these tests as well. Next slide, please. So here I'm just going to quickly sort of kind of move into the modeling point, and just want to kind of give a shout out to Global Fund, who kind of supported this work, and also find an ASLM. I'm going to really kind of focus on 5 countries from the Eastern and Southern Africa here. I'm not going to be showing you analysis we did for all 13 countries, but actually the trend is very similar across all of those countries as well. Next slide, please. So when we did the modeling, we were looking at a couple of things. First, we were looking at what is the actual testing need is. So first was basically based on if we want to test every single notified case. So the blue line is essentially everybody who gets notified for TB. If we actually now did a molecular test, how many tests would that be? And then if we actually tried to test for every single person incident case in countries, how many tests will be required? So currently, in 2026, we estimated in these 5 countries, you will require about 4.4 million tests if nothing changes, if we just continue testing the way we do right now. But if you want to test every single notified case, then we need about 7.4. And if you want to test for every single person, we're getting put to 9.5. Just to put this in context, like globally, we run about 20 to 30 million molecular tests. So to find every single notified case globally, we would probably require about 60 million tests. Next slide, please. And the reason, just to put that counter, like the 60 million test, or like essentially globally, that's, we know that it cannot be done all centrally. Like for us to be able to reach the access those people, it's not about the capacity of the central lab to be able to do it. It's actually about the whole system needed. Like, to be able to do all those things centrally, you would require amazing sample transport system, ability to return the results as well. So that's why we need to have tools that could be actually placed at the lower facility level. And Teju, the paper that she showed, when we did that modeling, and that's what we were looking at. We were trying to see, okay, if we try to increase access, what would happen? And essentially, by increasing access at a lower performance point, what we are actually gaining is, yes, the performance is low, but our loss to follow-up decreases. Because now there's no loss to follow-up, you could let the patient know right then and there, and you could put them on treatment. Whereas sample transport, even though LCNAT, GeneXpert, TrueNAT, they may have great sensitivity, but the problem is you end up losing 10 to 20% of patients because the patient might not come back to get their results back, and then we lose them until they come back again a few months later when their symptoms increase. Now, thinking about NPOC, we were also kind of trying to figure out, like, what are the actual potential use cases are. So we're sort of kind of been thinking about like 3 real use cases. I've sort of put in this priority, but essentially it would really kind of depend on country context. But one of the use cases we kind of see, the most promising use cases, sort of like replacement at microscopy sites. So wherever there's microscopy site, you could potentially place these devices. The second is expanding to PHCs. So where you have treatment centers, especially treatment centers that have a dedicated sputum collection, an HR who's responsible for doing sputum collection, that could be also a good place to place this. Because yes, the task shift can happen, but still the test takes about 35 minutes. So it cannot be done in front of a patient, essentially. So it's not like an HIV test where you can easily do it in front of a patient, and in about 15 to 20 minutes, you have a result. Here, there's multiple steps, and it will take you about 35 to 40 minutes to get a result. So you need to have a dedicated HR to be able to run the test. And the third use case is the supplement triage, which Melanie sort of alluded to as well, that putting this as where you have GeneXpert. However, I do want to caveat that, right? Because we know that cost containment is a use case and people will be interested in this, but here we have to be a little bit cautious though, because there would be drop in performance. So if you have already an LCNAT available at a site, so I'm not talking about referral samples, here you have that test at that facility, you're basically giving up a high performing test for a cheaper, lower performing test. So you might be actually losing maybe 20 to 30% of cases because you use that test. So here, you're not getting that scale of like gaining by increasing access and reducing the loss to follow up. So depending on the dynamics on how fast those results are returned back to the patients, you should really kind of take a second look and ensure that you're not losing patient by introducing the test here. Next slide, please. So we also kind of modeled to see, because we knew for some of these countries exactly where the microscopy sites were. And a lot of microscopy sites are actually referral sites, right? Because that's where the test, people take the sputum sample, and those sputum samples are sent to another centralized lab that does the testing. So we were trying to look and see, okay, if we turn those sample referral sites into testing sites using NPOC, but we were saying that you were actually shifting 76% of volume onto NPOC, and 24% would still remain on LCNATs. And so the advantage here is now that instead of referring those samples, you could run them right then and there. Now you're doing a cheaper test, but you still need to maintain that sample transport transport network, as Teju mentioned, that these tests do not have DST. So you still have to have the sample transport to be allow you to send a sample to a centralized lab so you could figure out whether the person had RIF or not. But at least the majority of the people, you'll be able to start them right then and there. And then you might have to just switch their regimen if they are drug resistant. But potentially, a lot more people can have access to the test at that point. Next slide, please. Additionally, then we looked at also how many modules will be needed there. And essentially, like in our analysis, nearly we just were able to what we found was pretty much all you need is one module. Majority of your more than 99% of sites might only require one single module. And these platforms are cheaper, right? They're about $400 a device. And that includes both the sample processing and the PCR analyzer. So here, I just want to point out, when we talk about GeneXpert and we talk about centralized platform, we tend to really talk about utilization rate. We try to say, you want to only place these devices where you have a high utilization because you want to try to leverage economies of scale. But with NPOC, economies of scales are actually different. Here, NPOC in economics actually allows for lower utilization rates. So even if I'm running a few tests a week, it's actually beneficial to put that device at that site. So, and because here our priority is to be able to bring these devices closer to the patient where they access care. Next slide, please. So overall, based on our assessments and country discussions, we really strongly believe that deployment strategy would be to prioritize should add first in microscopy and high throughput BHCs. Rather than just doing a blanket deployment where you put in every single facility in the country, I think it might be better to just first start off with those sites. Second, we need to have readiness enablers. We need to realize that these devices, yes, they're smaller. They seem portable. If you look at the PCR analyzer, it's very small. You could put in your hand. But the thing is, it comes with a sample and you also have a sample processing unit, which is a little bit heavier, a little bit bigger, and requires main power supply. So even though the infrastructure need is lesser than a GeneXpert-like device, these still have some infrastructure needs. You still need to have main power supply or a UPS system in place to be able to run the samples. So essentially, and also the HR as well to be able to do it. So you need to ensure that the sites that you're picking, they have those resources available so for you to be able to put this device. So you can't just do a blanket placement in every single facility like the way we might actually do with potentially with an RDT. Also, we still need to maintain our existing platforms. As everybody has kind of mentioned, there's no DST on these devices, so we still would have to rely on drug resistance. So we have to maintain our existing platform framework, as well as we need to keep strengthening our sample transport because that would still be needed. And finally, collaboration and sustainability. We need to ensure that we foster peer exchange between countries to be able to share the experiences, how they are implementing these devices, and then potentially learn from each other how best to implement this. Overall, I think NPOC are potentially very cost effective. Even at a low daily use, I would really want to stress that. Even at a low daily use, they are actually a better tool. But the success will really would depend on supply, smart deployment, readiness, and integration in the health system. Thank you, Alice. Happy to take questions right now or later.
Thank you so much, Shaukat. We do appreciate this presentation, and clearly we can see that we are building, each presentation is building on the previous presentation, but also the fact that this webinar is building on the webinar that we conducted on in September, and that was about maximizing the impact of newer and emerging diagnostics. Shaukat has shared a number of issues, key issues that we need to be aware of, and really bottom line, everyone speaking is talking about access, and bringing diagnostics closer to the people and closer to testing sites. So given the time that we have right now, we don't have so much time left, and yet we have one more presentation as well as a Q&A, my favorite of them all. And this is not to say that I am undermining the presentations. I love the presentations, but the Q&A really also shows me that actually our participants have been listening in very keenly and that they want to know more about the presentations. So first is that could you please remember to use the chat box? Shaukat is still with us until the end, so please place your questions in the Q&A chat, and then we will be happy to respond to them all. But remember, we also have a Q&A discussion at the end of the next presentation. But now we will move on to our next presentation, which is a presentation on TB, the TB diagnostics landscape in Nigeria, that is going to be presented by a colleague and friend, Olaide Akani, who is the National Coordinator for the Civil Society for the Eradication of Tuberculosis in Nigeria, or you can call it the TB Network. We are very happy to have you, Olaide, and we can't wait to hear more about the landscape in Nigeria. Over to you.
Thank you very much, Alice, and good afternoon, colleagues. Next slide, please. So just to highlight that, Nigeria, like we all know, and I think some of the previous speakers have alluded to that has a high TB burden. And not only do we have a high TB burden, we also have an overlapping TB and HIV burden, and we also have, high TB incidence. Nigeria is like sixth in Africa when it comes to the burden, and we contribute like 19% to the TB burden in Africa. So clearly it's important that we have a comprehensive and high quality diagnostic network to be able to rapidly diagnose TB and link cases to appropriate and timely care. And this has been like the Achilles heel for the TB program in the past. And thankfully, based on support from Global Fund and other partners, we are closely trying to bridge the diagnostic gap and ensure that, we're able to quickly diagnose people with TB and place them on treatment. Next slide, please. So if we look at TB diagnosis in Nigeria, we have a lot of factors, and guidelines that enable us to ensure that diagnosis is done in a timely manner. And the lab diagnosis for TB in Nigeria is in line with the National TB algorithm. And for the algorithm in Nigeria, the program plans to ensure that there's full coverage of diagnostic network platforms to meet estimated needs with continuous service and ensure that we achieve at least over 95% coverage of patients having access to MWRDs. We're not there yet, but there's a gradual process in moving to bridge the gap. And the plan is to have at least one optimized molecular platform per LGA. Just for a bit of context, Nigeria is divided across 774 local government areas, which we call LGAs. And the plan based on the operational plan for NTB-LCP is to have at least that in each local government area, there is one optimized molecular platform. Currently, Nigeria just stands around achieving 47% of that target. So we're still a long way off, but thankfully a lot of the services are being decentralized such that molecular diagnosis is brought closer to the people. Next slide. So this just gives us a pictorial of the National Diagnostic Network, and you can see that, we have peripheral laboratories, state reference labs, zonal TB reference labs, national TB reference labs, as well as the supranational reference labs. And on the right, you can see how each of these link with one another. In between, we also have systems to ensure that there is specimen and sample transport from one lab to the other as necessary, based on the tests that are conducted in the country. I won't dwell too much on that, but we can move on to the next slide. Now, this, I believe, is the crux of our discussion. Previous speakers have highlighted, some of the value add of near point of care and what it can do for TB diagnosis, how it can rapidly make a change in TB diagnosis across many countries. And currently, these are the diagnostic tools that are used in Nigeria. Of course, we talk about the GeneXpert, which is highly sensitive, and a lot has been said about the GeneXpert. And currently in Nigeria, we just have about 546 GeneXpert machines installed across 317 local governments, and when we talk about having 774 local governments, you can see that we're just like about 50% in terms of GeneXpert coverage. And, while people have argued about, the fact that we should be very strategic in how the GeneXpert machines are distributed across the country, there's also a lot of discussion about ensuring that even the ones that are available are well utilized and optimized. And then, of course, the TrueNut machines, they're portable, battery operated, and they work in, higher temperatures, which are very good, useful given our context in Nigeria. And currently we have just about 333 TrueNut devices nationwide in the country. It's actually 372, so I forgot to update that. So for TB-Lamp, which is used in places where, GeneXpert is not accessible and the infrastructure, and we don't have the infrastructure required, we currently have about 202 TB-Lamp machines deployed across the country. AFB microscopy, has been our mainstay over the years, and we have about 3,000 microscopy machines deployed across the country and counting. And of course, we also have the portable digital X-ray machines, which is the PDX machines, and increasingly they're being deployed in many communities, particularly when community outreaches are being conducted. They're definitely easy to move around. And we also have the benefits of the fact that we can also use AI to speed up the interpretations, particularly in remote settings. Currently, we have about 411 portable digital X-ray equipment deployed nationwide. Then, of course, the LF-LAM, which is a non-sputum sample testing platform for rapid diagnosis, particularly used for people living with HIV. And yes, it's currently available. We just have very few deployed across 28 facilities in 4 states. So we still have about 202, if I'm not mistaken, 202 TB-Lamp and LF-LAM deployed across facilities in Nigeria. Next slide, please. So this slide just shows you the extent to which these techniques have been used in country as of 2024. And you can see that, 80% of TB cases in 2024 were bacteriologically diagnosed, and over 68 point, a huge chunk, over 50% of those cases are still being detected using the GeneXpert machine. You can see that, the other devices are not utilized as much as GeneXpert, and there has been, a continuous push by the National TB Program to also ensure that even at subnational level, GeneXpert is not the first point, that people are increasingly using the TB lamp because, it's cheaper to use and it's more accessible rather than waiting for GeneXpert. But you can see from the data as at 2024 that increasingly the use of TB lamp is growing in country, and of LF-LAMP, there hasn't been a lot of utilization of LF-LAMP at community level. The use of TrueNAT too has grown, is increasing. I'm sure that by the time we have the 2025 data, it'll show a different picture, and so with the PDX machines. But we can see that as of 2024, there was still a lot of emphasis on the use of GeneXpert. But like I mentioned earlier, the national program is pushing that, state programs begin to use TB lamp as the first point of diagnosis, particularly in communities and in other AM settings. Next slide. In terms of DRTB diagnosis, you can see that in Nigeria, the lab diagnosis for DRTB is done by both genotypic and phenotypic drug susceptibility test. And in community outreaches, TB lamp is like the first test that is being pushed that should be used for diagnosis at community level. And then patients who test positive for TB lamp are then asked to be tested for, using GeneXpert, either for RIF or TrueNAT or for RIF resistance. And a positive clinical specimen tested by, the expert or TrueNAT showing resistance to rifampicin will now be further subjected to the expert XDR test, as well as or the line probe assay for first and second line, and also maybe culture or DST, as the case may be. Next slide, please. The other thing I did not mention, and I think Teju had also mentioned it in her earlier slide, is for TB diagnosis among children. Of course, we know that TB diagnosis among children can be quite difficult because oftentimes they're not able to produce sputum. And already, across the country, the program is really heavy on using stool samples, and that has been adopted across many of subnational levels. We just even recently completed a childhood testing week, and so stool sample, using GeneXpert is like the first point of call now for children with TB across the country, and that is being encouraged and scaled up. And so in terms of the turnaround time for the diagnostic tools that are currently in use in country, we can see that, for the GeneXpert, results can be gotten in about 24 hours, given that oftentimes, samples are pulled together. We don't do, because they have to be moved from maybe the community to the GeneXpert site and all of that. And to optimize the use of the machines, it's not one sample assessed per time, multiple samples are often used. And so that's why the turnaround time for the results might be maximum 24 hours. And then the same for TrueNAT. 24 hours, but when you need to do solid culture, liquid culture, that takes longer, particularly for, samples for DRTB. And then the line probe assay typically takes 1 week. The phenotypic DST liquid culture between 2 to 3 weeks, and then the phenotypic DST solid culture between 4 to 5 weeks. Next slide. So basically, that's about it. It's supposed to just be an overview of what's going on in the country. But one of the things I just also wanted to highlight is the fact that, it has been alluded to by previous speakers, in terms of distribution of many of these diagnostic equipment is still not evenly distributed across the country. And so definitely the new point of care test that we're all talking about will definitely be a game changer in terms of diagnosis for TB in the country. The other thing to note again is, having a diagnostic for children will be particularly welcome, given that we're still not doing very well as a country in terms of diagnosing TB among children and placing them on treatment. So those are 2 key areas that, going forward, this near point of care tests that have been discussed, particularly the oral swab, will definitely be a welcome addition to the toolkits that we currently have in the country as of now. Yeah, so I'll stop there. Thank you.
Thank you so much, Olaide, and I couldn't agree enough with you on the fact that we really need a near point of care diagnostics tools that should be brought closer to the people, to different access areas. Indeed, just like Shaukat did mention as well. We don't have so much time left, but we have a few minutes for Q&A. Some of you have been posting your questions in the chat. Thank you very much. And I see that their responses, our team of experts has been responding to you all. But at this point, I'd like to open up for anyone who wants to come off mute and pose your question before our experts leave or before the webinar ends. But in the meantime, we will continue with the Q&A in the chat for those who are most comfortable typing in the chat. Any questions? Please feel free to unmute and speak. Or alternatively, you can raise your hand and I will be happy to, the team will unmute you. That is if you're not unmuted, if the unmute is centrally done. Okay, in the meantime, those who are, we will wait to see if you're able to raise your hand. That will be okay. You raise your hand and we will unmute you. But some of the questions have been posted and responded to in the chat. Perhaps Shaukat and Olaide, would you want to come off mute and maybe elaborate a little more in detail on some of the questions that have been shared?
I guess I can. I think there was a question around like, can this be done by community workers? And essentially, the thing is that tests the workflow is simple. That they can be. The idea is that they should be able to task shifting should be able to happen. But honestly, this would really kind of depend on country regulations. In some countries, there's laws that need to be done by lab personnel or lab trained person. In some up to a healthcare worker level, but also when you think about like just the technology itself, as I mentioned, like it has 2 different devices and it requires main power supply. So I just from the technical point of view, I just don't want to have anybody to have this a misunderstanding that somebody can just throw this in their backpack and just show up at a household and will be able to run these tests. I think I would love to see a technology when it gets there, but at least the first few ones that might be coming to market, they might not be fit for that purpose. But there is a use case of doing active case finding. If you are potentially have an X-ray with you, you can with X-ray with CAT, you could go into the community, you could do active case finding, you can screen people with X-ray, and then you could provide them at the same time a molecular test as well. So, I mean, that is a use case we're actually interested in. We're actually going to be hopefully doing some implementation work to see the usability of that of running those an assay that way. So that is one assay. But I think at a household level at this moment, it's technically possible, but I'm not sure this is the fit for purpose tool though.
Thank you very much. That's very helpful. We appreciate. Olaide?
So yeah, I do agree with Dr. Shukat on this, that, clearly, even for the national program, you also want to eliminate situations where you're having false positives and all of that. And, they want to be sure that the tests are done in a consistent manner. So I imagine, just like it's currently being done with the use of TrueNat and PDX, the portable PDX machines. For community outreaches, there would always be like a technical person, a technician who is there, who administers the tests while the community mobilizes, the people. And at the end of the day, the results can be shared with the people, So typically, I imagine that there will be the national programs will definitely want to be sure that there are standardized ways of getting the results. So at this point in time, having people go from house to administer the test might not happen just yet, given that countries would even want to pilot this new test and see how it pans out, in reality on the ground. Yeah, thank you.
Thank you so much. Thanks to you both for bringing in that reality. And I also see someone mentioned in the chat that very good to see all these tools in the pipeline. We hope that they will be affordable at the end of the day. That is the assumption, but let's see what comes out of that. So some of you have been wondering whether we will be sharing with you the recordings of these webinars. Indeed, we will be sharing the recordings. We will be sharing with you the presentations as well. And we will definitely continue the discussion at a later point. We will share with you, we will invite you to the different webinars that will be coming up in the near future. But in the meantime, please keep on keeping on. Let's advocate for what communities need, bringing tools closer to the communities so that they are able to access diagnostics at the primary healthcare level. So at this point, I want to sincerely thank you all for joining this webinar. It's only because of you that we have had all these webinars as a success. A special thanks to our panelists, Sharon and Melanie, Shukat, and Olaide, as well as Teju, whose recording was played. Thank you so much for making this happen. And we look forward to continuing the discussion in the very near future. Wish you all a very good rest of your day. Bye.